First step is to look at the UA. This can be found under Results Review Urine. The specific gravity has to be 1.005 in order to detect WBC, nitrates, and esterase. If it is under that threshold, the urine is too dilute to delineate these things. Therefore, your UA may be falsely negative. Our lab WBC count cutoff for a positive UA is 5 to 10, unless someone is pregnant, neutropenic, HIV positive, history of renal transplant, or pediatric. 10 WBC in the urine is associated with 90% negative predictive value. Therefore, if you are lower than 10, you should question whether this is actually a UTI or if it is asymptomatic bacteriuria. A UA with greater than 100,000 bacteria is no different than a UA with 50,000 or 10,000 bacteria when it comes to whether you should treat or not. The amount of bacteria does not increase the likelihood of having a UTI. Treating is correlated with symptoms, risk factors, and positive UA. Asymptomatic UTIs typically do not need to be treated. Nitrite positive correlates with nitrate reductase. The only bacteria that reduce nitrates to nitrites are Enterobacteriaceae, E. coli, Proteus, Klebsiella, Enterobacter, Citrobacter, and Serratia. If your UA has nitrites and the culture grew Enterococcus, likely a gram-negative is what actually causing your infection. Do not target the Enterococcus. If the patient is immunocompromised and you isolated no other organism found from urine along with negative nitrites, absence of Enterobacteriaceae on UA, the Enterococcus should be targeted to be treated. If you isolate multiple pathogens with one being gram-negative rod and the patient is symptomatic, you likely do not need to target the Enterococcus in the urine with your treatment. If the patient is asymptomatic and they isolate Enterococcus, you do not need to treat colonized. If you have a septic patient with a positive UA who has improved without Enterococcus coverage, you likely do not need to target Enterococcus, especially if they are immunocompetent. Hyaline cast on a UA is indicative of upper kidney breakdown and correlated with a positive UA has a high sensitivity for polynephritis. If they have cast on the UA with negative nitrites in someone with a chronic Foley or acute short-term Foley, you need to cover Enterococcus. Enterase is a breakdown product of white blood cells. It shows WBC turnover, hence inflammation. This does not mean a UTI. This means that they have some reason for inflammation in their urine, i.e. Foley, straight cath, suprapubic catheter. WBC by itself does not mean you need to treat the urine. These patients mentioned will always have a WBC. Does your patient have a Foley? If you have a Foley, you will always have WBC. It does not mean a UTI that you have to treat. Typically, if you put the Foley, the UTI is gone. Some circumstances, you may need to pull the Foley and treat for a short course. Don't forget to look at the urinary excretion of your antibiotic to see whether it will work for treating a UTI.